Please take a pause of 2 seconds before you start.
Okay.
Juhi, go ahead.
Hello, everyone. A very good evening to all. My name is Juhi Thakur, and it gives me immense pleasure to extend a warm welcome to all of you on behalf of Hetero Healthcare. Today's webinar is focused on Perampanel Insights for Epilepsy Management. In the coming hour, we'll delve into the key aspects of this drug. The eminent speaker will shed light on some real world experiences with Perampanel in his patients. Also, if the attendees have any doubts during the session, can put in the query box present on your screen. All the doubts will be discussed towards the end of the session. Okay, so before diving into an insightful session, I would request Mr. Prasanta Pandey, DGM Sales and Marketing at Hetero Healthcare, to introduce the speaker of the day and to share few lines about Hetero Healthcare. Sir, over to you.
Good evening, all. Good evening, ladies and gentlemen, distinguished guests and esteemed participants, to each and every one of you. It is with great pleasure and excitement that I am here before you today to welcome you to this insightful webinar hosted by Hetero Healthcare Limited. Myself, Prashant Pandey, DGM Sales and Marketing of Hetero Healthcare's Leon Division, and I'm honored to be your host for this event. Before we delve into the wealth of knowledge our distinguished speaker, Dr. Vinay Kumar Agarwal, is about to share, let me extend my heartfelt gratitude to all of you for taking the time to join us from various corners of India. Your presence here today is a testament to your commitment to staying informed about the latest advancements in healthcare and epilepsy treatment modalities. Now it is with great pleasure that I introduce to you a highly accomplished, revered medical professional, Dr. Vinay Kumar Agarwal, an exemplary neurologist with an extensive list of laurels and achievements. Dr. Agarwal earned the prestigious DN in neurology from the renowned All India Institute of Medical Sciences, New Delhi in 1995. With a career spanning over 2 decades, Dr. Vinay Kumar Agarwal has been in private practice as a consultant neurologist in Bareilly, Uttar Pradesh since 1996. His unwavering dedication and commitment to the field of neurology have made him a beacon of hope for countless patients seeking expert care and guidance. Dr. Agarwal is a proud member of several esteemed medical organizations reflecting his commitment to staying at the forefront of advancements in neurology. His memberships include Indian Academy of Neurology, Neurological Society of India, Indian Epilepsy Association, American Academy of Neurology, American Headache Society, to name a few. This extensive list of affiliations demonstrates Dr. Agarwal's active involvement in both national as well as international neurology community, showcasing his commitment to continuous learning and collaboration with fellow experts. But before I pass the virtual microphone to our esteemed speaker, allow me a few more minutes to shed some light on the organizations that has brought us all together, Hetero Healthcare Limited. Hetero Healthcare Limited is a pioneering pharmaceutical company committed to making a difference in the world healthcare, established with a vision to improve and transform lives. Hetero has been at the forefront of developing and delivering high quality, affordable healthcare solutions with its 17 on field divisions of multidisciplinary support in retroviral therapy, antiviral, antibacterial therapy, gynecology, dermatology, gastroenterology, urology, oncology, neurology and psychiatry, anesthesia, and critical care products, to name a few. The company's commitment to innovation, research, and development has resulted in a range of revolutionary products that address some of the most pressing healthcare challenges of our time. From cutting edge medications to groundbreaking medical technologies, Hetero Healthcare Limited is leaving an indelible mark on the global healthcare landscape. What sets Hetero apart is not just its commitment to excellence, but also its dedication to accessibility. The company firmly believes that quality of healthcare should be within reach of every individual, regardless of geographical or economic barriers. This philosophy has driven Hetero to expand its reach, making a positive impact on countless lives around the world. In today's webinar, we will have the privilege of learning more about one of Hetero's groundbreaking products, the result of tireless efforts, innovative thinking, and a commitment to improving patients' outcomes. Our speaker will guide us through the latest advancements and shed light on how this product is shaping the future of epilepsy healthcare in India. As we embark on this journey of knowledge and discovery, let us keep our minds open and our curiosity alive. We are here to learn, to exchange ideas, and to explore the limitless possibilities that lie ahead in the realm of healthcare. Without further ado, it is my distinct pleasure to introduce our esteemed speaker, Dr. Vinay Kumar Agarwal, who will take us on a fascinating journey into the world of healthcare innovation, insights of epilepsy management. Please join me in extending a warm virtual welcome to Dr. Vinay Kumar Agarwal. Thank you, and let the webinar begin. Over to you, sir.
Okay, thank you, Prashant, for a nice introduction. And I think the topic today for discussion is, let me share my slide first. Yeah. Okay. So, as we know, as a neurologist, we see a large number of patients who are suffering from epilepsy. And we know that with the control of epilepsy, a large number of patients' quality of life changes. It is not only quality of life, at the same time, it's basically their job profile, their social life, their married life, everything changes with the control of seizures. For the years together, newer medications are coming up to control patients who are having refractory epilepsy. So, as far as the refractory epilepsy is concerned, various drugs have arrived. One of the drugs which has come recently in a sense in the last 5 or 6 years is one of the drug is parampanel, which is having absolutely a different mechanism of action. So I will be discussing about it a little bit later. As we know that in India, we have 10 million people who are suffering of epilepsy, and epilepsy, which is a disease very well controllable, and a large number of people are suffering from this illness. We know that currently what we are doing, we are having, most of the time we are using the molecules which are there for the long time, like phenytoin, carbamazepine, phenobarbital, and these are being used specifically in partial onset seizures, or as we now know, is focal onset seizures, may be motor or non-motor. The new molecules which has come up are oscarantine, topiramate, lacosamide, eslicarbazepine, lamotrigine, levetiracetam, brivaracetam, vigabatrin, and jonasamide for control of partial seizures or focal onset motor or non-motor seizures. What we do, how do we currently understand use of anti-epileptic drugs is that after conversion of failed monotherapy of a number of other medications, then we start adding a first add-on or second add-on to control epilepsy in patients who are having refractory epilepsy. As far as the polytherapy is concerned, there is no exact protocol which has been defined one, but usually the algorithm which is followed is we try to add medications which are having a different mechanism of action. And with polytherapy, we expect that a certain percentage of patients whose seizures are not being controlled will be controlled. As we see that with the years passing, we are having a large number of newer medications, anti-seizure medications, and in third generation, we are having parampanel, eslicarbazepine, clobazam, and Parampanel has come recently among all these molecules. Despite the availability of more than 22 anti-seizure medications, it is estimated that around 30% of newly diagnosed epilepsy patients will remain resistant to both drug monotherapy as well as to polytherapy. So this is a very big challenge. Around 30 to 40% have drug-resistant or refractory epilepsy. In India, around 3 million people or 30 lakh people suffer from drug-resistant epilepsy. It means out of 10 million, it's around 3 million people who are suffering from drug-resistant epilepsy. So what is refractory seizures? As far as the International League Against Epilepsy, which has proposed the definition of drug-resistant epilepsy, is that a person who has failed to become or stay seizure-free with adequate trials of 2 anti-seizure medications for adequate period. These seizure medications must have been chosen appropriately for the type of seizure type, should have been tolerated by person, and it may be tried alone or with a combination of other medication, anti-seizure medication. Seizures sometimes are not controlled with anti-seizure medication. A number of different terms may be used to describe these, including like in day-to-day practice, the words which may be used to describe refractory epilepsy are uncontrolled epilepsy, intractable epilepsy, refractory epilepsy, or drug-resistant epilepsy, or even pharmacoresistant epilepsy. It connotes the same meaning. What are the causes of refractory epilepsy? Exactly, most of the causes are unknown, but some of the factors which are responsible for a refractory epilepsy may be that the patient may not be having epilepsy in itself, the diagnosis of patient may be wrong, or the patient not receiving the proper anti-seizure medication for the type of epilepsy or seizure he is suffering. There are some of the predisposing conditions where most of the time patients may end up with the refractory epilepsy, like patients with refractory seizures, patients with head injuries, patients are having infections, fevers, or brain tumors. And of course, sometimes lifestyle factors also make epilepsy refractory to medication. Suppose if a patient is having sleep-deprived seizures, if you start with anti-seizure medication, sometimes these patients don't respond only to anti-seizure medication unless until they take precautions to take adequate sleep. So, why we are worried about refractory epilepsy? Because it can reduce the quality of life. Patients may have various mental health issues like depression, anxiety, along with this refractory epilepsy. These patients may have memory and learning issues. There may be sleep disorders associated with refractory epilepsy. There is definitely a risk of falling, drowning, or driving during driving, risk of accidents, patients who are having refractory epilepsy, because the most significant risk of injury because of seizure. There may be some side effects of some medications which may be troublesome for patient. Patient may end up with the status epilepticus if he is having refractory epilepsy. And of course, there are problems related in pregnancy and sudden unexpected death of epilepsy, which is a real danger in patients with refractory epilepsy. The other challenges regarding refractory seizures are intellectual disabilities, poor developmental outcome, and other associated comorbidities such as depression, which I have already discussed. Moreover, it is associated with poor quality of life because of the side effects of medications, associated comorbidities, and of course, not able to achieve independence in their life. As far as the drugs used in management of refractory epilepsy is concerned, as far as Cochrane analysis is concerned, Cochrane reviews have demonstrated that clobazam, eslicarbazepine, gabapentin, lamotrigine, levetiracetam, ostarabine, tiagabine, topiramate, vigabatrin, and zonisamide are all effective as add-on treatment for refractory partial seizures. However, there is a little guidance from published literature as to what order these agents should be trialed, but many look to combinations with different mechanisms of action. Probably this becomes an algorithm for us, different mechanisms of action, and at the same time side effect profile of a medication. So, as we know that a large meta-analysis incorporated 30 incorporated results of 54 studies involving 11,000 patients, which demonstrated that after correction of placebo, anti-seizure medication used as add-on in refractory epilepsy resulted in seizure freedom only in 6% of patients. Only 21% of these patients of refractory epilepsy has a reduction of seizures of more than 50%. So you can understand from this very well that how big burden is there of refractory epilepsy, that only 6% of the patients can become seizure free. So why there is a need of new drug for epilepsy is because we know that refractory epilepsy patients, we have seen burden of refractory epilepsy patients. And not only this, most of the anti-seizure medications which we are having, they have a very, you can say, prototype of mechanism of action. There are few prototype of mechanism of action, like many anti-seizure medications, they work on channels like phenytoin, carbamazepine, oxcarbazepine, lamotrigine, lagosamide, and jonosamide. There are few medications we work through GABA receptors, and there are few medications we work through the SV2A receptors. So practically, there are if you divide into group, there are three groups. One are working through channels, second GABA receptors, and of course, third is through SV2A receptors. But if we can find out another way of mechanism of action through which we can control seizures, this is going to be another feather in the treatment of refractory epilepsy. So here comes the role of perampanel. As we know that there are glutamate receptors which are excitotoxics. There are two types of glutamate receptors. One is NMDA and another is MPA. If you control NMDA receptors or you have anti-NMDA receptor activity medications, they actually don't control epilepsy. Rather, in some of the patients, there is deterioration of control of epilepsy. But if you control AMPA receptors, which are also glutamate receptors, if you block these receptors, there is a control of seizures in these patients. So that's why the AMPA receptors become important in the treatment of epilepsy. The studies have shown that there is a high glutamate concentration near AMPA receptors. AMPA receptors mediate fast excitatory transmission in CNS, which has a key role in the generation and spread of seizure activity. So initial part of fast excitatory neurotransmission is governed by excitation of AMPA receptors, which is stimulated by glutamate excitatory neurotransmitters. Perampanel, which is a new, novel, non-competitive, it is a basically non-competitive, selective antagonist at the postsynaptic AMPA glutamate receptors. So I like to highlight few words. That is a new, one of the newer medication which has a different mechanism of action. Second, it works on the glutamate receptors. And third, it works through non-competitive way. It doesn't work through the competitive way, blocking way. So once the action potential is generated, glutamate are released from the vesicles and it binds to AMPA receptors. What does the perampanel does? Perampanel basically binds to AMPA receptors and it decreases the neuronal firing. This way, it reduces the chances of epilepsy attack. So this is the place where the perampanel works. Why perampanel is a non-competitive antagonist? Perampanel does not replace, or perampanel is not replaced by high concentration of glutamate concentration. It means if a medication is having a competitive antagonism, then a high concentration of glutamate will replace its action or will inhibit the action of a glutamate receptor blocker. But if it is a non-competitive blocker, whatever may be the concentration of glutamate receptor activating molecule, its effect will not be blocked. At the same time, low doses of that particular molecule will be required to block those receptors. So perampanel fits with that. It blocks non-competitively. Even high concentrations of glutamate are not able to stop the action of perampanel. At the same time, the low doses of perampanel are sufficient enough to work against the AMPA receptors. From this cartoon, you can see that these are the glutamate receptor binding sites for AMPA, and this is here the glutamate binds. And with the binding of glutamate, what happens in a normal stimulation, sodium enters inside the channel, and then the channels, once the glutamate is dissociates, the channels are closed and they return to normal. But in the presence of competitive antagonist, if suppose these are the glutamate and this is the competitive antagonist, but if this concentration of glutamate increases, it can overpower these competitive antagonists. So the purpose of reducing the excitation of glutamate receptors or AMPA receptors will be defeated. So in the presence of parampanel, which is a non-competitive AMPA receptor blocker, which blocks it here, so whatever may be the concentration of glutamate, it is not going to affect the transmission through this channel after blockage of AMPA receptors. So this is the advantage of competitive versus non-competitive blockers for glutamate receptors. What are the indications? As far as the indications of or the approval of parampanel is concerned, in the US, parampanel is approved for the treatment of focal onset seizures with or without bilateral tonic-clonic seizures in patients over the age of 4 years as add-on as well as monotherapy. So parampanel can be used in focal onset seizures with or without bilateral tonic-clonic seizures, patients who are more than 4 years of age. Either you can use it as a monotherapy or you can use as add-on. It is approved as add-on in patients with primary generalized tonic-clonic seizures who are having a refractory epilepsy and whose age is more than 12 years of age. So for primary generalized tonic-clonic seizures after the age of 12 years, you can use as add-on, whereas partial onset seizures, you can use even in pediatric age group as an add-on or as you can use it monotherapy. As far as the pharmacokinetic parampanel is concerned, absorption, that is time X is 0.5 to 2.5 hours. Protein binding is 95%. Metabolism is hepatic. Half-life is quite long, 105 hours. Excretion is through feces and urine. The advantage of long half-life with parampanel is this, that you can give in OD doses, and sometimes if a patient misses a single dose, most of the time it is not going to affect the control of a seizure of a patient. You are not required to immediately load with another dose of parampanel in these patients. What is the doses of parampanel? Usually we start with 2 milligram daily at the bedtime. It should be increased very slowly so that patient can tolerate it. And if you increase it very fastly, it becomes very difficult for the patient to tolerate it. So you increase the dose based on the clinical response on tolerability, and you may increase 2 milligram once daily, once in a week, or even longer than that. As far as the maintenance dose is monotherapy or add-on for partial onset seizures concerned, the usual doses which are required is 8 to 12 milligram once daily at bedtime. For primary generalized tonic-clonic seizures as add-on, the usual maintenance dose is 8 milligram per day. Now coming to what evidences we have for the use of parampanel in patients with refractory focal onset seizures or generalized tonic-clonic seizures. So this is a famous study in which it was used as first add-on patients who are receiving a single anti-seizure medication and who are failing for controlling focal onset seizures with or without secondary generalization. In this, 106 patients were included. The primary endpoint was the percentage of patients who are having more than 50% reduction in seizure frequency. The secondary endpoints was the patients who are having more than 75% of seizure reduction in seizure frequency. At the same time, to evaluate what percentage of patients are becoming seizure free. And this trial initial 8 weeks for screening for these patients for the inclusion. Titration period was 12 weeks. In the titration period, this was increased very slowly from 2 milligram per day. It was started, and after every 2 weeks, it was increased by 2 milligram, and the total titration period was 12 weeks. After titration of 12 weeks, these patients were maintained for 24 weeks for on this on that 5 compa dose, on that dose of perampanel. During the titration period of this phase 4 study, patients received 2 milligram perampanel once daily at bedtime. The daily dose was increased incrementally at 2 weeks interval by 2 milligram, depending on the clinical response and tolerability. If you see overall response during the 24-week maintenance period, you can see that this is the group of patients who are having partial onset seizures or focal onset seizures. And this is the group of patients who are having focal to bilateral tonic-clonic seizures. This you can see that more than 50% of patients, responder rate was 80% in partial onset seizures. And as far as the focal to bilateral tonic-clonic is concerned, 87.5% of the patients responded for the control of more than 50% control of bilateral tonic-clonic seizures, focal to bilateral tonic-clonic seizures. So the longer the period the patient received the medication, the better were the response for these patients. So this is the number. This is again the number of patients who had reduced seizure frequency, partial onset. This is the partial onset with secondary generalization. So 50% reduction was there in 68 patients, and 14 patients who are having secondary generalized. More than 75% reduction was there in 61 patients, and more than 100% means the patients whose seizures were completely controlled were 40 patients out of 85 patients who are having partial onset seizures. The most common side effects were dizziness, somnolence, and headache. The patients who discontinued this perampanel because of adverse effects, these were only 13.2% of the patients. 3.8 patients withdrew because of withdrawal of consent. 2.8% patients were withdrawn because of major protocol violation, and 1.9% patients were lost to follow. There was 2.8% of the patients, there were different reasons because of which they discontinued this medication. So perampanel was effective and well tolerated as a first add-on to monotherapy patients with focal onset seizures with or without secondary generalization seizures, as far as this famous study is concerned. The other important indication which for perampanel is as an add-on in patients who are having primary generalized tonic-clonic, primary generalized epilepsy, who are refractory to monotherapy. To assess the efficacy and safety of add-on perampanel patients with drug-resistant primary generalized tonic-clonic seizures seen in idiopathic generalized epilepsy, total 164 patients were randomized. 162 patients comprised they continued to comprise the full analysis set. The perampanel during a 4-week titration period, it was increased from 2 milligram to 8 milligram, and or the possible highest dose, and 13-week was the maintenance period in these patients. The primary endpoint was percentage change in primary generalized tonic-clonic seizures frequency per 4 weeks. The key secondary endpoint was that more than 50% seizure reduction in primary generalized tonic-clonic seizures. So median percent change in primary generalized tonic-clonic seizures, from here you can see that the patients who were on perampanel, it was 76.5%, whereas in placebo it was 38.5% only. So compared with placebo, perampanel conferred a greater median percent change in primary generalized tonic-clonic seizures frequency per 28 days, that is 4 weeks. And this difference was significant. Not only this, the perampanel conferred a greater median percent change in primary generalized tonic-clonic seizures and was associated with a greater 50% seizure responder rate. Again, it was significant. Here you can see the placebo is around 40% of the patients whose seizure reduced more than 50%, where the patients who were on perampanel is around 64% of the patients whose seizures reduced more than 50%. So during the maintenance period, 12.3% of the placebo treated patients and around 30% of the perampanel treated patients achieved freedom from the seizures. 4.9% of the placebo treated patients, around 24% of the perampanel treated patients achieved seizure freedom from all seizures. That is different type of associated primary generalized epilepsy. At week 12, that is after completion of maintenance period, 33% of placebo-treated patients and 40% of perampanel-treated patients were considered much or very much improved according to the scale which was used. So, add-on perampanel 8 mg was well tolerated and effective in improving seizure control in patients who were more than 12 years of age or older and who were having drug-resistant primary generalized tonic-clonic seizures in idiopathic generalized epilepsy. Perampanel in refractory seizures is concerned to assess efficacy and safety of AMPA receptor antagonists when added to concomitant anti-seizure medication in the treatment of drug-resistant partial onset seizures. It's a study 304. There were 388 patients who are having, the age was more than 12 years of all these subjects. The doses were used 8 to 12 milligrams and 19 weeks was the study design period, out of which 6 weeks was the titration period and 13 weeks was the maintenance period. So you can see that the 12 milligram patients, the patients on 8 milligram and the patients who were on placebo. So more than 50% of seizure reduction was much more in patients who are receiving 12 milligram in comparison to patients who are receiving 8 milligram, and this was significantly better in comparison to patients who were receiving placebo. As far as the summary of the add-on trial, perampanel add-on trial, the important trials which has been 305 and 306. The once daily add-on perampanel at the doses of 8 to 10 milligram improved seizure control in patients with uncontrolled partial onset seizures. The doses of 8 to 10 milligram were safe and tolerability was acceptable. This trial demonstrated that add-on perampanel effectivity reduced seizure frequency and possessed a favorable tolerability profile in patients more than 12 years of age who are having partial onset seizures or focal onset seizures with or without secondary generalization. Though it could be seen that the minimum effective dose was 4 milligram per day. It means you can see the effect of perampanel even at 4 milligram, the 4 milligram per day. As for the long-term safety of perampanel seizure outcome in refractory partial onset seizures is concerned, in study 307, it was a large extension study for 3 years follow-up. This included 249 centers, 39 countries, and patients who had completed one of the 3 phase trials, the important trials, the region trials for 304, 305, 306. They were eligible to participate. Patients entering the extension were up titrated 2 milligram after 2 weeks from the dose on which they finished their core study, that is 305, 306, or 304. And from 2 milligram for patients who were on placebo, increased to 12 milligram or individual maximum tolerable dose in these patients. So from there you can see the important response was there initially in the 1 to 13 weeks and 14 to 26 weeks initially. So in whatever the doses these patients were taking, and even further follow-up, the best response was itself visible in the initial few weeks. As far as the long-term open-label perampanel is trial, GTCS trials, idiopathic generalized epilepsy is concerned, The objective was to assess the long-term efficacy and safety of add-on perampanel up to 12 milligram per day in patients who are having more than 12 years of age, who are suffering from primary generalized tonic-clonic seizures. 138 patients were included. Perampanel 8 milligram for 4 weeks or 10 milligram for 13 weeks were used. Median percentage reduction in generalized seizures per 28 days from perampanel was 77% from first to 13 weeks and is increased to 90% from week 40 to 52. The retention rate was very good, 88% 6 months and 75% at 12 months. Seizure freedom rates were maintained at least 2 years regardless of the prior treatment, whatever the patient was receiving during the choricity. So perampanel was generally well tolerated and treatment related adverse effects reported, which were seen in perampanel for safety profile. They were not a significant concern, and perampanel offered a long-term treatment option for patients with more than 12 years of age with generalized tonic-clonic seizures who are having a refractory GTCS. As far as the perampanel efficacy and tolerability in patients who are receiving already enzyme-inducing anti-seizure medication is concerned, it was seen that in the trial, 306 patients were who are having pharmacoresistant partial onset seizures. These patients were randomized to either 8 milligram, 12 milligram, placebo, or 248 milligram per day of doses in 304, 305, and 306 study. 6 weeks dose titration was there and 13 weeks maintenance period was followed. And it was seen that the perampanel shows efficacy and safety in presence or absence of enzyme-induced drugs. As systemic exposure to perampanel increases, so does the efficacy. So this is the patients who are not having enzyme-inducing medications. It means that there was a more exposure to perampanel. These patients responded better. Usefulness of perampanel with concomitant levetiracetam for patients with drug-resistant epilepsy. The major concern remains regarding while using perampanel with concomitant with levetiracetam is basically the behavioral side effects. It was seen that if it was used with concomitant levetiracetam, perampanel proved to be useful in concomitant use with levetiracetam with drug-resistant epilepsy, and seizure-free status was significantly more frequent among patients with levetiracetam than among patients without levetiracetam. Aggression was present in 2 patients without levetiracetam, but none with levetiracetam. Perampanel refractory seizures already discussed, and this 311, this core study that was done to see the efficacy and safety profile of perampanel syrup in pediatric patients. So these are the comparative studies which compared perampanel versus levetiracetam. The more patients withdrew from levetiracetam because of adverse effects compared to perampanel at 3-week and 12 months follow-up visits. The better tolerability of perampanel observed in this study could be related to the low therapeutic dose of perampanel prescribed when it is used as a first add-on treatment for better controlling the partial onset with secondary generation seizures. As far as the behavioral side effect is concerned, levetiracetam perampanel, the important issue is, of course, the issue of aggression. When we compare behavioral negative side effect levetiracetam versus perampanel, it revealed that levetiracetam appears to have a negative effect on a much broader range of behavioral effects than perampanel. Perampanel, which specifically seems to induce aggression, irritability, and no other side effects, whereas it has been seen that levetiracetam is a much broad spectrum of behavioral abnormality. Perampanel versus brivaracetam is concerned, there is no direct head-to-head trial. It was a basically indirect comparison. It was seen that the perampanel and brivaracetam are effective for the adjunctive treatment of focal onset seizures, and the side effect profile was the same. Perampanel demonstrated an improved focal onset seizure responder rate compared to brivaracetam in patient taking concomitant levetiracetam. As far as the efficacy and safety of perampanel in refractory and suprarefractory status epilepticus is concerned, it's a cohort study of 81 patients. Literature was reviewed. It was seen that perampanel is effective and has a satisfactory safety profile in emergency treatment of established refractory status epilepticus and super-refractory status epilepticus. As far as efficacy, tolerability, and safety of perampanel in a population with pharmacoresistant focal seizures is concerned, in a systemic review and meta-analysis, perampanel was observed to be an effective add-on drug for treating pharmacoresistant focal seizures, and patients achieved higher 50% respondent rate in comparison to placebo. What are the side effects of perampanel? Most common adverse reactions associated with perampanel are dizziness, somnolence, fatigue, irritability, falls, nausea, weight gain, vertigo, ataxia, headache, vomiting, confusion, abdominal pain, and anxiety. And to overcome this problem, the best strategy is to go slowly and to titrate very slowly the doses of perampanel in patients who are having refractory epilepsy, whether you are going to use first add-on or second add-on. Its use in severe renal impairment is not recommended. Hepatic impairment in severe is not recommended. As far as pregnancy is concerned, there is not sufficient data to provide any recommendation. As far as pediatric age group is concerned, this use has been approved in children who are having more than 4 years of age, either as a monotherapy or as an add-on. As far as the warning and precautions perampanel is concerned, suicidal behavior and ideation. Monitor suicidal thoughts and behavior in patients who are having these behavior abnormality already. Best is to avoid use of perampanel in these patients. Drug reaction, that the dress should be looked into. If it is there, discontinue it. If you can practically establish that this is occurring because of perampanel. In patients, sometimes there can be paradoxical increase of seizures. If this happens, then withdraw the medication. As it is metabolized by CYP3A4 in liver, so there are enzyme-inducing drugs which can reduce its blood level and they can increase its clearance. So accordingly, you have to increase the doses of perampanel. If perampanel is being used 12 milligram per day, it may decrease the effectiveness of hormonal contraceptives which contain levonorgestrel. When moderate to strong CYP3A4 inducers are introduced or withdrawn, patients should be monitored closely because you have to adjust the doses of perampanel accordingly. So perampanel is an AMPA receptor antagonist. It's a new medication, new mechanism of action. Perampanel can be used in both generalized tonic-clonic seizures and partial onset seizures. Partial onset means focal onset seizures with or without generalization. Perampanel has proven to be effective in drug-resistant epilepsy. Half-life of perampanel is 105 hours. We say advantage to it. Perampanel is given once daily at bedtime and dose can range from 2 to 12 milligram and titration should be done slowly, preferably not to increase 2 milligram per day before 2 weeks. The maintenance doses can range from 6 to 12 milligram, and long-term safety study showed that perampanel was well tolerated as add-on treatment for pharmacoresistant partial seizures. Perampanel and brivaracetam are effective for add-on treatment for focal onset seizures. Perampanel has been useful to be used in concomitant for levetiracetam without increased risk of behavioral side effects. So, despite the availability of more than 22 anti-seizure medications, it is estimated that around 30% of newly diagnosed epilepsy patients will remain resistant to both drug monotherapy and polytherapy. Thank you. very much.
So you can stop presenting the screen. Yeah, thank you. Yeah, Juhi.
Yeah. Hello, sir.
Hello.
Yeah.
Yeah, 1 minute. So we'll take up the questions now.
Yeah.
All the participants can put their questions in the query box presented on their screens. We'll wait for 2 minutes and then we'll start taking the questions.
Right. So meanwhile, she's taking up the questions. We have in general two questions for you, which is normally seen in field works and while interacting with your colleagues. So, sir, first of one is somnolence. When you use perampanel in your patients, so they are getting somnolence when they are going for up titration. So, how to
Yes.
cope up with this? How to cope up with this thing to give a respite to the patient as well as to get rid of so much somnolence?
Yeah, uh, absolutely right. This is one of the common problem which is faced while using the parent panel, and this is the reason that first of the one of the reasons that it is given in night time is this basically because of somnolence. It is preferably given in the night time. This region. Second, of course, if you titrate parent panel very slowly, then most of the time you can overcome this problem. Very slowly in a sense that you can judge from very first dose how this patient is going to behave with next escalation of dose. So normally you increase what you do from 2 milligram to 4 milligram, you go after 2 weeks. Okay. But you feel that the patient is not able to tolerate it, you can increase rather than for after 2 weeks, you can increase after 3 weeks or 4 weeks also. So it is basically slow titration, and the higher the doses you go, it is better to go much slower. So that way you can deal with it. Very likely you can do.
Thank you. Another question which normally gets put up by your colleagues that since you have gone through this presentation and you have repeatedly said that it could be given to other indications also apart from the refractory epilepsy, but actually in India, normally this is being used as third, fourth, or maybe fifth add-on, and in case of maximum case of refractory epilepsy itself. So, is there other things where you have used parenteral apart from refractory epilepsy and you got a good result out of it?
Yeah, what change I have seen in practice, in my practice, yeah,
Right.
I have been using parenpanel a lot. That means initially it was being used as second add-on or third add-on. Okay. With the experience as the time is passing, it has switched over from third add-on, second add-on to first add-on.
Right. Sir.
If you use as a first add-on, the results are definitely better in comparison if you use second add-on or third add-on. So I will say this is one of the newer indication. You can take it that way. And second, as you know, it has been approved even for monotherapy in partial onset seizures,
Right.
With or without second action.
Right. Sir.
So if suppose a patient is having a drug reaction to initially use anti-seizure medication, like phenytoin, he has developed a skin rashes to it. It is expected that he may have cross reaction or cross allergy or cross skin rashes if he use carbamazepine, oscarabine, lamotrigine, or phenobarbital in these patients. So you have one more armamentarium, you have one more medication in your armamentarium. In these patients group, to use as a monotherapy, first. And second, sometimes the compliance of medications is affected because if a patient is using doses in a BD doses or TDS doses. We have advantage with perampanel that it is very long half-life.
Right.
So you are using in OD doses. So that gives you an advantage as far as the compliance is concerned. You have sufficient data now and already approval is there. You can try to use it or you can use it as a monotherapy rather than using it as a first add-on or second add-on. So and of course, the other indication is sometimes we are faced with a challenge of refractory primary generalized tonic. That is a really big problem. There, you can always use as a first add-on, though we don't have a recommendation or approval to use as a monotherapy. But of course, always you can use as a first add-on, and the results are really gratifying. And we know that to control primary generalized tonic-clonic seizures is sometimes very difficult task to control with other medications. So I feel these are some of the compartments where we can enter and utilize its efficacy that way, where we are not doing it right now.
You rightly said that few newer studies are coming up and recently done in AIMS also related to this monotherapy because when going to field and talking to other neurologists, they are actually currently using this in the first add-on or maybe in monotherapy also. So, what do you think about the use of or the dosage pattern of this injection, if at all brought in India? Because currently it is in US FDA approved, but not present in India.
I feel it should be a very useful tool in our basket because perampanel has been shown to be effective not only in refractory epilepsy, in refractory status as well as super refractory status. So it is going to be useful.
And it
is
will be
going to
useful
be
for
yeah.
status of epilepticus also. In that
Yes.
case, you need emergency setup, and
Yes.
for that injections have 100% bioavailability.
Yes, because it has a different mechanism of action. Already we have been using different medications for status epilepticus. You know that initially only phenytoin was being used, or first phenytoin was being used for status epilepticus.
Right.
Now we are using sodium valproate, brivcetam for status. So that way, if we see that the patient is not responding to these, then of course we can use in refractory status and super refractory status. So those injectable preparations definitely has its place to play.
Right. So Judy, if you have received any questions, so you can ask something.
Yeah, we did receive one question. It was on sedation. So it has been cleared. And then there's this one comment that doctor has given all the important instructions and topics are well covered.
Thank
So,
you.
yeah.
So, sir, in that, just a few question on the perspective of marketing. Still, if we have one or two questions left within next few minutes. So, sir, we have seen in the market trend, this is not growing in the way it should be. As on paper, it is very safe. As on paper, it is very effective. But at the same point, if we see the market as a view, it's not growing. So, do you think that it is related to the awareness level of the parental in among the users, or maybe the somnolence, or maybe any side effects, or maybe anything apart from these?
Now, I feel it's a is exposure to basically literature, what I'll say, because initially it was promoted and it has occupied our mind with the promotion that it can be used as a second hand on third hand. That too, it means the patients who are really very refractory. Okay.
Right.
So with the coming of newer data where it can be used as monotherapy as first add-on, I think its use should increase if we make the people aware of the recent literature. So I think that's the prime reason what I feel. Because once a concept is formed that it is for this purpose, it becomes difficult to change without literature. So now, once the relevant and adequate literacy is available, if we proceed with that, I think that idea will change. Definitely. I feel there are like my experience says as I have my practice has changed in a sense that it is a medication which can use OD. This is one of the best advantages, you know, as far as the compliance is concerned. Second, such a long half-life, if a patient misses a dose, you're not that much bothered as you are
Right.
bothered about other anti-seizure medications.
Right, sir.
Yeah. And third, of course, absolutely different mechanism of action. So these are the few points which makes me think and which has made my practice change that from third add-on, second add-on, coming to first add-on. And I am very happy in using it specifically in patients who have a refractory primary generalized tonic-clonic seizures. It was very difficult. We literally had a very few molecules to use it. And now we have a very sound molecule to use it with a robust data to use it. So I think if we make a sound, if we make a proper sound, that it can be used not only in as a second add-on, third add-on, it can be used as a monotherapy and first add-on, and we have sufficient data, I think then it is going to pick it up.
So another question, in your daily to daily practice, maybe I'm just asking you, maybe on not on data, but in your daily to day practice, you have used levetiracetam also, you have used many other molecules also, and you have used perampanel also on the other hand. So what is the ratio? Maybe 1:2 or maybe 2:1, whatever the ratio could be. Just a number. The interactal phase between the levetiracetam treated patients and the perampanel treated patient, because you have just mentioned about the dosage pattern, so the half-life pattern. So do you have any such an observation during this thing?
Can you just make it more clear?
Sir, in levetiracetam treated patients, interactal phase,
Okay.
the time interactal phase, and the this with perampanel, the interactal phase. Is there any definite base gap?
Uh, Gap means
matlab, if a person is
can
taking
you just
levetiracetam, yeah,
okay,
if a person
yeah,
is taking levetiracetam
yeah,
and he maybe forgets to take medication for 1 or 2 days,
okay,
immediately
okay,
seizure can persist, or
yes,
maybe there is a when you are treating with levetiracetam, there is a significant gap of the seizure-free time, and in
yes,
case
yes,
of perampanel, they have their time also. So,
yes.
do you find any ratio or safer ratio as far as levetiracetam and perampanel is concerned?
Of course, like as I already discussed, the perampanel has a very long half-life. Okay,
Right.
if a patient or levetiracetam, if that patient misses a doses for 2 or 3 days, really I am
Right.
worried. And I am, if patient comes up to me, I am going to load that patient with the IV levetiracetam. If a patient with perampanel, if he misses a dose, I'm not that bothered. But at the same time, suppose he misses a single dose, I'm going to ask him, next day you take a scheduled medication, scheduled time. Depending, of course, at the same time, depending whether the patient is taking perampanel with enzyme-inducing drug or without non-enzyme inducing. The
Non.
dose and duration is going to depend on that. But I will not be that much worried if he misses a single dose, but I will be definitely worried if a patient on levetiracetam misses a single day doses. And
Right.
yeah, and ratio is quite significant. Ratios are quite significant in a sense. They must, there will be a large chunk of patients who will develop seizures if they miss a levetiracetam. There is a minimum number of patients who will develop a seizure with the missing of dose with perampanel.
Right. Thank you,
Yeah,
sir.
sir.
Judy, yeah.
Yeah, we have this one question from Dr. Nikhil Bhamre. He's asking, sir, in my practice, I prefer lacosamide as first add-on and perampanel as a second add-on. So what is your choice?
Yeah, my choice, like if suppose choice of lacosamide versus perampanel will depend what the primary drug patient is using. Suppose a patient is using primary drug which is a sodium channel blocker. My choice will be perampanel, considering it's a different mechanism of action. And if you use another sodium channel blocker, I will feel not be that comfortable as with the drug with a different mechanism of action. Second, at the same time, if you are using two sodium channel blockers, of course, that works on a different type of sodium channels. The addition of adverse effects, if you use two medications with almost the same working profile, that there is likely to be more adverse effect in comparison to if you use two medications which are having a different different mechanism of action. So if a patient is already on sodium channel blocker, I will use perampanel. If a patient is on, suppose, levetiracetam already, then I may use lacosamide, depending on the patient profile, other factors. So my primary decision will be on the basis of what the primary drug patient is taking.
Right. So, Judy, do you have any other questions?
Okay. So, no, not right now. I hope Dr. Nikhil, your queries are cleared. If you have any more questions, you can put it in the query box.
So, we can take it up another 5 minutes if somebody give a question. Otherwise, we can call it a day. Thank you, doctor.
Okay.
I think you need to make more sound about this molecule.
Right,
Okay.
sir. That is what I am also concerned about this molecule because in previous um, assignment I have this molecule, and at the same point of time, at that point of time, what you have said is scientifically correct, and all those things are. But at the same point of time, due to the knowledge or maybe the other molecules which are currently being prescribed in large numbers in Indian market. This is something else. Another way I thought is sedation was another issue and the titration was another issue in colleagues who have shared with me in between that they have found this molecule very good. They have found this molecule very safe and they have used it, but at certain point of time, few people have called them immediately within first day or maybe second day that the patient is having so much sedation and they ultimately needs to taper it up. So that creates a problem for them. This was the scenario. And yes, obviously the noise level. So we will take it up, sir.
No,
Yeah.
as for the sedation, of course, as far as the somnolence, if I have to discuss my experience,
Right.
like what I do, I have learned also from patient,
Right.
how to circumvent this sedation problem. Now with the availability of syrup is also there. Okay, you can even start less than 2 milligram doses first, and second, what happens? Suppose you have started with 2 milligram and you increased 4 milligram after 2 weeks. And if you feel that the patient is having a sedation, you can always rebuild his confidence by counseling him that, okay, I'm not going to increase after 2 weeks. What you do, you continue with the 2 milligram. You increase after 3 weeks or 4 weeks. First thing. And what I have seen that the patients usually, they tolerate it very well. First. Second is, suppose a patient, he's taking two medications in the night, suppose. One medication he takes at 8 p.m. What usually patient does, they take both the medication at the same time, perampanel and other medications. Okay. So he is going to, suppose he develops sedation with perampanel. He will experience sedation. What I suggest these patients, because perampanel is a very long half-life. Even if patient's medication is delayed by 2 hours, it is not going to make a difference.
Right.
Suppose he's taking BD medications morning 8 a.m., 8 p.m. I suggest him take the perampanel once you are going to sleep. Don't take at 8 p.m. So you will not face that kind of a problem. Second.
Right.
And third, you have seen that most of the time you come to know whether the perampanel, how it is behaving with 4 or 6 milligram of doses.
Right.
Okay. After using 4 milligram, 6 milligrams, you suppose you have used 4 milligram and 6 milligram, you come to know that it is not helping patient. So there is no point in pushing further.
Right.
And you feel that the patient is doing well with 4 milligram, but problem somnolence is there. You can come in between with 3 milligram, like 2 milligram, 1.5 tablets. Then after a few weeks, you reach to 4 milligram. Okay. And third, what I have seen from patients, as I told you, that some patients, they started using themselves. Suppose I prescribe them 4 milligram. What they have started doing, half tablet in the morning, half tablet in the night. They are able to tolerate it. And they are doing well. So 4 milligram, they are taking 2 milligram BD. And they are tolerating it well. Their problem has gone away. And rather than somnolence, what I have seen with patients is basically dizziness, what I have seen. Most of these patients, they complain of dizziness. So if they are taking at the bedtime, particularly elderly patients, they wake up in the night time because of like various comorbidities. But young patients, they don't wake up. So dizziness or somnolence is more of a problem with elderly patients because they have to wake up in the night time, suppose for urination, prostate problem. For young patients, this problem is not there. So if they take it bedtime, that problem can be taken care. Or maybe in future, if there comes a sustained release preparation.
Right, sir.
Yeah, that can further solve this problem. But if you feel it is effective, I have never seen that I have to withdraw perampanel because of this problem.
Right.
It's how you titrate it, how you progress it. Always you can manage it if patient is responding to it. The main problem comes when you increase more than 6 milligram. 4 milligram, most of the time, no problem. 6 milligram, few patients. But if you increase more than 6 milligram, then majority of the patients start complaining. It becomes difficult to manage. And not only this, my experience is, suppose you are using it as second unknown in a patient. Suppose patient is already taking one sodium channel blocker, he is taking clobazam, and you have added perampanel. You add perampanel, patients suppose develop somnolence. What I have done in these patients, I have slightly reduced the first add-on medication, continued with the perampanel. They are able to adjust it. So you have to find out the strategy individually in each patient. But if you are confident enough and you feel that the patient is going to respond to it, is responding to it, so there is no reason that because of somnolence, you are going to withdraw it. It's basically your strategy. You plan it, patient will manage it. Or you give a free hand to patient to manage it. He will teach you.
Yes. We have this one last question from Dr. Vijay. Why is perampanel taken at night?
It's already discussed. The main reason being, there are two reasons what I feel. Most of the time, even whatever the medications patients take, suppose it is not anti-seizure medications, any other medication for any other illness, if it works in OD doses, most of the time patients prefer to take in the night time so they don't forget it. Wherever they are, at the dinner time, at the bedtime, they don't forget. If they take in the morning time, most of the time, suppose any other medication which is being used in OD doses, in the morning time, there is a chances they will forget it. So if any medication which is being used OD doses, always most of the time patient will ask us, sir, can I take in the night time? Then I ask why? Because the compliance is better, first aspect. And second, of course, as far as the pharmacological aspect is basically dizziness and sedation. If a patient takes in the night time while going to sleep, that is taken care of. Once he gets up in the morning, it's not a problem. So these are the two reasons which I have seen. One is compliance. If we take nighttime dose, they are much more compliant in comparison to OD dose if they take in the morning time. Second, of course, we have a compulsion to use with perampanel. Second compulsion is regarding dizziness or somnolence. Third, as I have discussed, there are few patients taking BD doses. So it's not must that we can use only in OD doses and that too in the night time, but these are the reasons to be used in the night time preferably.
Thank you, sir. Yeah, Juhi, you can
Yes.
continue with the vote of thanks.
Yeah. Yeah. I hope, Dr. Vijay, your queries are answered. Yeah. So thank you so much, Doctor. So now, as we draw curtains on this enlightening webinar on perampanel, I would like to express our heartfelt gratitude to each and every one of you for being a part of this insightful session. Our deepest appreciation goes to our distinguished doctors for their valuable presence, since their enthusiasm and curiosity have contributed significantly to the success of this event. Also, special thanks to our speaker, Dr. Vinay Kumar Agarwal, for sharing his experience with all and enlightening us. As we move forward, let's carry the wisdom gained from today's discussions into our lives. Once again, thank you to our doctors, speakers, and all the participants for making this webinar a resounding success. We look forward for future collaborations and continued advancements in the field of innovative management. So yeah, thank you, doctor. Thank you for answering
Thank you.
all the
Thank you.
doubts.
Thank you,
very
sir.
much.
Pranam.
Thank you.
Thank you.
Yeah, thank you.